Steve, you've been involved in drug research and policy for the best part of 30 years. What's changed in that time?
Well, I've certainly lost a lot more hair. We've seen a number of changes over the last 30 years, but a couple of things that stand out for me are, if you look at young people, there seems to be an increasing polarization of drug use. So on the one hand, just using alcohol as an example, on the one hand, certainly within Australia, we've got fewer young people who actually drink, and many young people who drink very little. On the other hand, some of their mates are making up for it. So average alcohol consumption doesn't seem to have changed that much, but what has changed is that some people are drinking very large amounts of alcohol. And we're seeing similar things in relation to illicit drugs as well. For example, within Australia, the number of people who report that they're using cannabis has dropped by about 40%. But those who do use, some of them seem to be using at an earlier age on average, and seem to be using much larger amounts. So we've gone from 30, 40 years ago where somebody might share a joint once or twice a week with 4 or 5 friends, to seeing people in treatment services who are cannabis dependent, who are using 4 or 5 or 6 or more times in a single day. So that sort of intense use, I think, has changed. Clearly, we've seen an increase in the new synthetic drugs over the last few years, and that's creating new challenges for us, both in terms of we hardly know what the acute effects are, let alone what the long-term effects are. And of course, the mode of distribution of information and of the substances through the internet creates new challenges for public health, for law enforcement, and so on. Going to the other extreme, if you like, of age, we're beginning to see an aging population worldwide. The population is getting older, so over the next 10, 20, 30 years, we're going to see a big increase in the aged population. And we're seeing people who are taking their drug using history with them into older age. So certainly when I started out, if you worked in the drug field, most of the clients you saw were fairly young. I suppose they're still fairly young now because I'm a much older person, but what's happened is we're now, drug treatment services are seeing people who have been using for 20, 30 years. They're seeing clients who are in their 40s, 50s, even 60s. And that's creating new challenges. We've got people who have been using for a long time. They're having health conditions that come as a consequence of age and sometimes a consequence of long-term drug use. And so this is a very new challenge for many of our clinical practitioners.
Why do you think we've seen that polarization of use, that it's become more acute in the minority of young people?
It's hard to say with any sense of authority. I think a number of factors are likely suspects. I think firstly, for example, we have seen a big decline in many countries of tobacco use. And tobacco is associated with other drug use. So early onset tobacco use is a predictor of other drug use. I think some people have got the message about the risks and so are perhaps a little more alert to some of the health risks and so on, and indeed now the reputational risks. So perhaps it's the health. And the reason I say that is, for example, again, in Australia we have the National Household Survey, and what we've seen in relation to cannabis is coincidental with cannabis use going down on average over the last 10 years or so. We've seen an increase in the perceived risk of cannabis use. So there is this perception of an increased risk. Now, whether that's come about because of formal education campaigns or whether it's come about because of coverage in the media, I'm not sure. And so, but it's very hard for me to say, well, it's because of X or Y. I think it's important that we actually understand what's going on because it has some important implications about how we might better do public health, and it has some implications for how we need to invest more in dealing with this new issue. I think with alcohol in particular, the increasing availability of alcohol has had an impact. we've seen in many countries an increase in the hours of sale, a relative decline in the price relative to disposable income for young people. We've seen a big increase in the number of outlets, and so all of that, I think, for some people does increase the risk of alcohol-related harm. There's longer to drink more. And associated with that, of course, some people will take stimulant drugs such as caffeine, energy drinks, or amphetamine in order to mask the effects of alcohol, in order to drink more for longer.
You talked about an increased awareness of risk among young people, an apparent increase. Does that suggest, in the case of cannabis, that an appeal to people's care for their health may be more effective than the law?
I hesitate because I want to say yes, but I think we have to be a little bit more cautious than that, because we're not clear that, for example, messages about health from public health people is actually what's caused the change. Has it been the coverage in the media? Has it been the stories in movies? Has it been what we do in schools? It's very hard to actually say it's because of X or Y. And I think we also have to recognize that while people like me as a more than middle-aged public health person might be interested in health and think that health's an important motivator for behavior, I've got to recognize that other things may influence young people. Their reputation may matter more than their health. What they think their peers are doing may have a greater influence. For example, we know that many young people overestimate whether or not their mates use drugs, and then they overestimate how much their friends actually use. And those overestimations have an influence on their own behavior. So it may be that it's been messages about health. I'd love to say it was, but I think there's a whole range of other things that may have had influence, and I'm not certain that what it might be. It's probably a combination of a whole range of different factors.
I'm getting the impression from you that the research, the finding of fact is one thing. Actually designing a policy response is in a way harder?
I think it is. And I think it is for a number of reasons. Policy responses are often simple, short-term, and not necessarily well-funded. And that's for a whole variety of reasons. There is often a disconnect between what the evidence tells us is the best way to go and what actually happens. And that's for a variety of reasons. A lot of the responses are short-term, poorly funded, single-focused, when in fact the evidence tells us that the influences on drug use are multifaceted. So for example, if you simply take a risk and protective approach, we know that what protects young people from drug-related harm is being well connected to school, well connected, and that means social and academic competence, not just turning up, well connected to adults, to culture, to community. And the risk factors are things like personal vulnerabilities, family functioning, availability in the community, what they think their peers are doing, how rich their environment is or how poor their environment is. That means that these are things that we need to take into account in responding to drug use. It's not just about making sure people know what the risks are or know what the law is. Those are important, but they're not necessarily sufficient to make change. We need to ensure that we engage young people in school from an early age. We need to ensure that families that have good communication skills, where people become disconnected from adults, we rapidly connect them back into their community and adults. That we're able to target vulnerable families or vulnerable communities, that we build employment and recreation and what some people might call spiritual opportunities. For me, that may include religion, but it also includes things that are not about material gain. So if that is the case, and consistently evidence suggests that those are important, that means that the interventions we need to embrace need to include all of those facets. What tends to happen is we get a short-term program on drug education in schools. Most of the time, those sorts of programs don't show much impact. Sometimes they show a negative impact. That's not to say that people don't have a right to education. It's simply that we, as one of my colleagues once said, we shouldn't set fantastic objectives. If somebody's at risk of using cannabis because they live in a poor quality environment where cannabis is easily available, where they overestimate what their peers do, where there's very little else to do, simply giving them a couple of hours inoculation in schools, not sufficient. We need to invest in a broad range of strategies. Now, we've had that sort of investment with tobacco. In many Western countries, we've had an investment in enduring, well-resourced education programs, changes to the availability of tobacco, both in terms of price and number of outlets, changes to the environment in terms of where people can and can't smoke, strong educational messages in school, in the community. All of these things combined over a long period of time, we've seen a massive impact. Really fantastic public health success. With drinking and driving in countries such as New Zealand and Australia, we've had campaigns, changes to the law, highly visible random breath testing, so that people have a perception that if they do drink and drive, they'll get caught. It's had an impact. So that we know that programs that are well-resourced over a period of time and are multifaceted make a difference. If you look at communities, some small Aboriginal communities in Western Australia where they've reduced the availability of alcohol and they've started to build community investment and involvement, it's had a massive impact on public health. So we can make a difference, but we're unlikely to make a difference with single-focus, short-term, poorly resourced programs. In terms of any review of our legislative approaches, my sense is that, from a researcher's point of view, is that we need to take small steps and evaluate their impact rather than blind leaps into the dark that we may later regret.
A lot of what you were saying about the social, community and spiritual factors maybe can be summed up as a reason to get up in the morning.
Yes. Obviously, if your life is miserable, if you are dealing with drudgery or trauma, distress, drugs can become a functional way of dealing with that. Now, I'm not trying to say that everybody who uses drugs necessarily is traumatized and so on. Many people get into drug use because they want to try the effect and they live in robust communities and have lots of other things going on in their lives. But people who get enmeshed, who find it difficult to get out, are often the people who are the least advantaged in our community.
Are those least advantaged people helped or hindered by the criminal status of cannabis?
I think if we have a criminal-only approach, then firstly it's not sufficient and indeed it can make things worse. I think that for me, we actually do need a combined approach. We do need a legislative approach. That's clear from our experience with a whole range of legal and illegal drugs. And I must say, I have no sympathy with people who profit from the sale of drugs. But I think when people are in possession of drugs for their own personal use, I think that's where we actually need to lead with a much stronger public health response. For me, it's a personal and a public health issue as opposed to simply a criminal response. And if you only have a criminal response, there's always going to be someone willing to supply drugs because the profits are so high. What you actually have to tackle is the things that influence people's decision to access drugs and the demand for drugs. But in answer to your question, a law enforcement approach in terms of supplies is something that I think we need to consider. What that looks like I think we need to review. On the one hand, it's clear to me that some of the things that happen with our current legislative frameworks are don't have the intended outcomes and sometimes have adverse outcomes. Now, I don't take the leap to then say, well, let's just legalise them. I mean, we don't do a very good job of dealing with some of our legal substances either. But what I would say is I strongly endorse that we should have a public health approach to individuals who consume drugs, and that that needs to be at the forefront of a response, and that we need to review and refine the law enforcement approaches to the supply of drugs.
Steve Allsop, thank you for your time.
Thank you.